analyzed carefully in each ECG. Now, how to evaluate the rhythm? Evaluate the rhythm strip at the bottom of 12 lead for following. Is the rhythm regular or irregular? Is there is a P wave before every QRS complex? Are there any abnormal leads? So you have to check whether the rhythm is regular, whether the P wave is followed by QRS complex. You have to check. So that is how you should check for the rhythm. Now, heart rate. So, how will you calculate the heart rate? So, rule of 300 or 1500. 10-second rule. So, what is rule of 300? Count the number of big boxes between the two QRS complexes. So, two QRS complexes you have to check. So, if you see a big square, then count the number of big boxes between the two QRS complexes, and there you have to divide this into 300. Smaller boxes with 1500. If you check the big box, then it should be 300, and if you count smaller box, then it will be 1500. So this is a rule of 300. So remember this, count the number of big boxes between two QRS complexes and divide the number into 300. If you take smaller boxes, then with 1500 for regular rhythm. So here you can see the QRS complexes, and you can see a large box here, 1 2 3 4 5, and we can consider this half and this as a 6. So 300 divided by 6, that is number of large boxes. So approximately 50 beats per minute is the heart rate. So I will repeat rule of 300. You have to take two QRS complexes and you have to count large squares in between two QRS complexes, and you have to divide those number. So 300 divided by 6 is equal to 50 beats per minute. Here this is the QRS. So 1 2 3, approximately 4. So 300 divided by 4, 75 beats per minute, which is normal. Here very less, so you can take one and half. So 300 divided by 1.5, that is 200 beats per minute. So this is tachycardia or tachyarrhythmia, you can see. Now the PR interval. So what is PR interval? It indicates the atrial depolarization. You can see this PR. So it indicates the atrial depolarization and delay in AV junction. So this delay allows the time for atria to contract before the ventricles contract. Normal PR interval is 3 to 5 small squares, that is 0.12 to 0.20 second. As we have already seen, one small square is equal to 0.04. So 3 to 5 small square means 0.12 to 0.20 seconds. Short PR interval you will see in WPW syndrome, that is Wolf Parkinson's White syndrome. So you should know what is the importance of PR interval, in which condition the PR interval is short, what is the normal duration of PR interval. Short PR you will be seeing in Wolf Parkinson's White, that is WPW syndrome. So in this syndrome there is a extra electrical pathway in a heart which causes a rapid heartbeat. And this extra electrical pathway appears between the heart's upper and lower chambers, and it is present at birth. So, extra electrical pathway, remember this. And in long PR interval, you will be seeing in first degree AV block. So, what is first degree AV block? So, it is a disease of electrical conduction system of heart in which the electrical impulses are conducted into the heart. So, this is also a conduction defect. So, that is long PR. You will be seeing in first degree AV block, and in WPW you will be seeing short PR interval. Normal PR interval is 0.12 to 0.20 seconds. So this is the long PR interval, first degree AV block. So this is PR. So PR interval, long PR interval. You can see the short PR interval, very short PR interval here. It is present in WPW syndrome. Now BBB, that is bundle branch block. So what is it? So conduction in the bundle branches and Purkinje fibers are seen as the QRS complex on the ECG. Therefore, a conduction block of bundle branches would be reflected as a change in the QRS complex. So you can see this is a normal in V1 and V6. In right bundle branch block, you can see this R dash pattern. And in left bundle branch pattern, you can see this is the W in V1 and this M in V6. And there is a T wave inversion you can see in V6 in LBBB. Now the right bundle branch block. RBBB, the wide QRS complex assumes a unique virtually diagnostic shape in those with overlying the right ventricle. So M shape in V1. You can see here M shape in V1 and sometimes in V2 also. So you can see this is the M pattern RBBB. In LBBB, broad deep S wave. You can see the broad deep S wave. So for LBBB, the wide QRS complex assumes a characteristic change in shape in those leads opposite the left ventricle, that is right ventricular leads, that is V1 and V2. So you can see the broad and deep S wave, that is LBBB. So you can see here broad and deep S wave here. Now QT interval. So this is your QT interval. So QT interval is measured in lead AVL as this lead does not have prominent U wave. Remember, QT interval is measured in lead AVL. QT interval includes the total duration of ventricular activation and recovery. When the interval is to be measured from single lead, the lead in which the interval is longest, most commonly the lead AVL, V2 or V3, and in which a prominent U wave is absent, should be used. The normal range for QT interval is rate dependent. A commonly used formula was developed by Bassett in 1920. The result is corrected QT interval or QTC. It is defined by the following equation. So corrected QT is QT divided by RR interval. This formula is important. Sometimes in competitive exam they ask to calculate how you will calculate the corrected QT interval. So corrected QT interval is QTC. So it is calculated by the QT interval divided by the RR interval. That is corrected QT interval. The upper normal limit be set at 450 or even 460 milliseconds. The Bazet formula remains significantly affected by heart rate, and that as many as 30% of normal ECG would be diagnosed as having a prolonged QT interval when this formula is used. One formula that has been shown to be relatively insensitive to heart rate is, so this formula is very insensitive. So we won't consider it. So we will consider that formula only. Corrected QT interval is equal to QT interval divided by RR interval. Now where you will see the prolonged QTC, that is corrected QT interval. So during sleep, hypocalcemia, acute myocarditis, acute myocardial injury, drugs like quinidine, procainamide, tricyclic antidepressants, hypothermia, cardiomyopathy, hypertrophic obstructive cardiomyopathy, then prolonged QTC in advanced AV block or high degree AV block, then Jarvel Lange Nelson syndrome you can check, then Romanov syndrome. So these are the condition where you will get prolonged QTC. Short QT interval, digitalis effect, hypercalcemia, hyperthermia, and vagal stimulation. So these are very important. Prolonged QTC and short QTC. I'll just repeat. Prolonged QTC is seen in during sleep, hypocalcemia, acute myocarditis, acute myocardial injury, drugs like quinidine, procainamide, tricyclic antidepressants, hypothermia, hypertrophic obstructive cardiomyopathy. Prolonged QTC. Again, you will be seeing in advanced AV block or high degree AV block, then Jarvel Lynch Nelson syndrome, Romanov syndrome. Short QC, I already discussed digitalis effect, hypercalcemia, hyperthermia, vagal stimulation. Now, what does this mean? P wave signifies atrial depolarization. QRS is ventricular depolarization and T wave is ventricular repolarization. So you should know this is the basic thing. P wave signifies atrial depolarization. QRS complex signifies ventricular depolarization. T wave ventricular repolarization. Now what is P wave? P wave always positive in lead 1 and 2. So you will always get a positive P wave in lead 1 and 2. P wave is always negative in lead AVR. Less than 3 small square, that is 0.12 second in duration. Less than 2.5 small square in amplitude. Commonly biphasic P wave in lead V1 and it is best seen in lead 2. So if you want to see P wave prominently, you have to check for lead 2.